All right, everyone. So we're going to wrap up the models for the lab exam for Unit 4 here in just a couple minutes here. We're going to talk about the respiratory system. Before we get there, though, the lymphatic system, we don't really have much in the way of models for the lymphatic system. We do have the torsos that you guys will remember from lab. And usually what we do is have you identify the spleen, identify lymph nodes or lymph vessels. I think I'm going to focus on the lymphatic system mostly in the lecture exam. I may have you identify the spleen, where you would find lymph nodes, what's the difference between lymphatic vessels and blood vessels. But since we don't have very good pictures of that, I'm not going to do that in the lab exam. So let's move on to the respiratory system now. And so for the respiratory system, what we're going to be looking at here is the upper and the lower respiratory pathways. So where I usually divide the upper and the lower respiratory pathway is right around the epiglottis at the trachea. And so what we're going to be first looking at is the external nares, some people call it nares, the external nares, where the air comes into the upper respiratory pathway here through the nasal cavity. We have some sinuses here, some nasal sinuses. The sinuses are separate from the upper respiratory system. We have the superior, middle, and inferior nasal concha here. So I'm looking on my list to make sure I'm hitting all the high points for you guys on your study guide. What's the purpose of the nose and this upper nasal cavity that ends in this is the internal nares, or basically it's the hole through which the air flows through the upper respiratory pathway or the upper nasal cavity down to the pharynx. Up here would be the cribriform plate. Remember, that's where we have the olfactory bulb. So the purpose of this region here is basically, we don't have it on this model, but there are hairs in here that help filter incoming air. It humidifies and moistens incoming air, because by the time air gets down to the alveolar sacs and deep in the lungs, the air needs to be warmed at least a little bit. It needs to be somewhat humidified, because cold, dry air is very harsh on very delicate tissues. And so it helps protect the tissues. In addition, the hairs and the mucosa, the olfactory mucosa, will be trapping particles, trapping chemicals, of course, things that we smell, but helping protect us from inhaling particles and drawing it deep down into the lungs. So we have the primary portion here of the nasal cavity. Back here is the pharynx. The pharynx is basically the back of the throat. If you take biology, the pharynx is actually pretty interesting. The pharynx, the back of the throat, is something that's very well developed in mammals, not very well developed in fish, for example. But the pharynx is where you'll see the joining of the nasal cavity with the oral cavity. So this is the nasopharynx, and this is the oral pharynx. So it's the back of the throat, the top of the back of the throat. Up here we have the palatine tonsils. Actually, the palatine tonsils are here. Up here, I call them the adenoids. Adenoids is a lymphatic tissue, along with the palatine and the lingual tonsils. The lingual tonsils are farther down. And the adenoids and the tonsils are a part of our immune system. These are sites where basically immune cells develop, they populate the nasal system, the pharynx, and they help protect us from nasty things like bacteria and viruses that come in through our respiratory pathway. As we age, the adenoids regress. They become much smaller, so that when you're an adult, they should not impede airflow. In children, however, because they can get so large, sometimes children have issues with breathing. They'll snore a lot at night, and so sometimes doctors go and take those out. The same with the palatine and the lingual tonsils as well. So here, back here is your nasopharynx. This is the oropharynx, leading down into, eventually, right here is the esophagus. I'm sorry, the trachea. And right here's the esophagus, all right? Sorry, I said that backwards. I'm used to looking at another model where the head is oriented the other way. And so this separation here occurs at the level of the epiglottis. Now the epiglottis, when we come down here, we'll be able to see in a minute, Right here, you're looking at a posterior view of the larynx. The larynx is right here on this model. The hyoid bone, you can't see it on this model well. The hyoid bone's right over here. And so the posterior view of the larynx is going to show you the respiratory pathway, and when we look at it on the other side, you'll see respiratory and digestive pathway. Here is the anterior view. You'll see the laryngeal cartilage here. You guys remember what the name of this gland is? The thyroid, remember that? And then right here we have circular pieces of cartilage protecting the trachea. Now, one of the things about the trachea is that the trachea is made of a tremendous amount of connective tissue, which includes like not so much elastic connective tissue, but cartilage, which are these blue rings here, and lots of collagen. And so the trachea is meant to be held open, all right, so that air can travel in and out. It's kind of the physiology of it. Right here, looking at a sagittal view, we have the epiglottis, and the epiglottis is going to gate back and forth between the trachea and the esophagus. So the trachea is going to be anterior, the esophagus is going to be posterior, and we don't have the esophagus in this cross section here. Up here you can see the laryngeal cartilage right here and right here, and when you look at the anterior view, here's the laryngeal cartilage, and here is the thyroid. You can see the cartilaginous rings here. The voice box, or the larynx, is localized up higher, so I'm going to come back up here to show you a posterior view. So the larynx is made up of a series of muscles and tissues that, and you'll see this in the lecture, that allow air to flow over the tissues in such a way that vibrations are set up, and the vibrations are then focused up through your upper respiratory system for making vocalization. Human vocalization is quite a bit different from any other mammalian vocalization. Having said that, there are many animals that have laryngeal type structures that allow them to communicate with one another. For example, in songbirds, the larynx isn't actually called the larynx, it's called the syrinx, but it's kind of structured in a similar way. So let's scroll down here onto our respiratory model. So basically what we're looking at here is the subdivision. We talked about the nasal cavity, which is part of the upper respiratory system, coming down to the trachea and the larynx. Now we're going to start talking about the lower respiratory system. So here's the trachea and the tracheal cartilage, branching eventually, we'll see this in a minute, into the right and the left lobes of the lung, or sides of the lungs, right and the left lungs. The right lung here, remember the right lung of the patient is your left, is subdivided into 3 regions, 1, 2, and the third is down here. The left lung is subdivided into 2 regions. So you have the superior, the middle, and the inferior lobes of the right lung, and the superior and the inferior lobes of the left lung. Now, one of the interesting things that I've always appreciated about the lungs here, especially the left lung, is the left lung is missing that middle portion. Well, that happens to be just enough space for our heart to fit into the little edge here of the superior lobe of the left lung. So there's an evolutionary developmental step that's allowed the development of enough space around the heart. Now, the heart and the lungs are going to be separated by the pericardial and the pleural sacs. The pleural sac, as you remember from lecture, is a sac, a double sac of tissues that surround the lungs, and between the 2 layers is fluid, just like the pericardial sac. There's a layer of fluid, and what that does is both the lungs and the heart are moving a lot while we're alive, especially while we're walking around and moving and doing things. The increase in respiratory and cardiac rate is going to increase potentially the amount of rubbing that happens or friction that occurs between the tissues. So having these pericardial and pleural sacs, pleural membranes separated by fluid, allows a smooth motion to occur without accumulation of friction, which means you're not going to end up with scar tissue developing in those regions. So we're going to end there. Oh no, let's do a little bit more up here. I forgot I put my respiratory models up at the top. My apologies. So when we're looking at the respiratory system, we don't have a model necessarily of the alveoli. You're going to have to be looking at your lecture material for that. But the lungs in cross-section, you can see the superior, middle, and inferior lobes. There are fissures separating the lobes. What could those be named? Might be something to think about for the lab exam. We have the superior and inferior lobe of the left lung. Here you can see the primary bronchus invading or infiltrating, we say infiltrating to enter, into those tissues, branching into secondary. We do not have fine enough discrimination in drawings here to show necessarily the tertiary and terminal bronchi ending in alveoli, but that's kind of what these kind of gray bumpy regions are. Remember, surrounding the tertiary bronchi is going to be a tremendous amount of smooth muscle. That's where you're going to end up with contraction and relaxation of smooth muscle that leads to changing the diameter of the bronchial pathways leading in and out of the respiratory system in the lungs. That type of contraction and relaxation will control airflow, and when you inhale something, let's say that you're allergic to, when bad things are starting to come in, your body will signal the contraction of that smooth muscle, which cuts off not so much flow into the lungs, but airflow out of the lungs. And that condition is called asthma. Asthma induces air trapping inside the alveolar spaces of the lungs because air can't go back out. And so people who have chronic asthma have issues with developing what's called cyanosis, where you're getting an increase of CO2 in the bloodstream as a consequence of not being able to get air out because of air trapping, right? And so what ends up happening is they start hyperventilating because the body is trying to get rid of the CO2, but the air can't go out, and so they hyperventilate more and more, and that eventually leads to an asthma attack. You'll talk about that a heck of a lot more in physiology, and we link that with the immune system after that's happened quite a few times. Remember we talked about in the blood cell, in the blood lecture, we were talking about blood cells that get into the alveoli. Eosinophils in asthmatic patients tend to escape into the alveoli, and so you'll have a condition called eosinophilic asthma. And so what the eosinophils start doing is spitting out histamine like crazy, inducing inflammation inside the lungs. Well, the lungs don't like that. You end up with leakiness, you end up with other issues. And so in eosinophilic asthma, what ends up happening is the individual has a lot of inflammation in the lungs, and so doctors will tend to treat chronic eosinophilic asthma with hormones, with different products, inhaled products, different inhalers that, like budesonide, that fight inflammation in the tissues locally. And that's a really good treatment because it's actually targeting the source of the inflammation. After the histamine dies down a little bit, then the smooth muscle and other triggers start relaxing, and the individual can breathe more freely. Anyways, that is my review for the time being of our lab models for the lab exam for Unit 4. If you have any questions, let me know. I do have office hours, so please come and visit me.